Yeah, so we have our next very energetic panelist, Dr. Sanjay RASAL, who's going to be talking, and he's a consultant at SANJAY, Netralaya, Maharashtra. And we look forward to another very interesting video which he has to show. On to you, Dr. Sanjay. But your
so I said, good evening, very lovely panelists over here. And thank you, Chitra Madam, for having me here once again in this ARC program. I given a name to this video, Picture Abhi Baki Hai Mere Dost. Just Shail Vasavda has already highlighted, don't take the things for granted until you finish the case totally. And when you have a Sunday with exhaustive discussion on a cataract surgery, I don't expect everyone to be fresh on the Sunday morning. So the same thing happens when you have a heavy OT day and you have a last case, your IOL is properly loaded, you have done a wonderful phaco, and it's a matter of just hydro implanting the IOL, and you are eager for the coffee break. Now you are injecting the IOL and you have a situation where you see your IOL is totally crushed into the anterior chamber. Now, here I request Chitra Madam, I request permission from the Chitra Madam to pause this video because I want to ask few questions here. Why this happened, what could be done, and how this can be prevented in further cases. The case is open for discussion, Chitra Madam. And we will see a remaining part of the case after the discussion.
Was there not enough visco loaded while you were implanting this lens?
That's why I already showed the loading of the IOL at a first place. If you see, there is a copious of visco is placed onto the cartridge on both groove, and the IOL was well.
Was it a wound assisted thing where you put too much pressure, or the plunger was overriding?
No, see, it's a hydro implantation of the IOL, and it is not a wound assisted. My distal tip of the cartridge is well inside the anterior chamber.
Yeah, then
was this a new IOL?
New IOL, the material of the IOL is questionable here.
IOL it's a hydrophobic IOL, hydrophobic single piece IOL.
Is this a new IOL? Something that you have not used before?
It's a revision from IOC. It was a new IOL, yes.
So maybe some of these.
So there's a problem with the compatibility of the new IOL with the injector that you're using,
or with the cartridge.
And probably it will be in a learning process. So you were one of the first targets.
No. You are right. Could be that cartridge that is provided by the assistant, and the assistant might have opened another cartridge. That is one possibility. But what I feel that for several years I am hydro implanting the IOL, and I thought why not to save the time. Every time I need to exchange the IA from left to right for the cortical aspiration, rather than exchanging the hands every time and coming out and loading the IOL. I loaded the IOL before IA and kept on the trolley, and it got stiffened. It got hard in the cartridge. By the time I finished IA, the IOL material got very steep and hard, and I really felt the resistance while injecting the IOL. It was really impossible to inject. I kept on pushing and pushing. At that time only, I could have stopped injecting the IOL and withdrawn the procedure there only. But I was eager to have a coffee break just now. Like we all must be feeling that desperate coffee break after a long time of a discussion. So in the eagerness of having coffee break, I landed in a trouble and extended my OT session half an hour. So I rotated this IOL to bring this cut part in along the tunnel, and I had no option but to cut this IOL in a multiple small pieces with the IOL cutting scissor, that is a crocodile scissor. Copious amount of viscoelastic, that is cohesive and dispersive visco, is injected below and above the IOL to protect the delicate structures like corneal endothelium, and posterior capsule below, and of course the CCC margin, which is very important. This IOL is again divided in two pieces. Every time the Sinsky or dialer is kept into the entry chamber onto top of the IOL piece to support it, should not tumble and should not damage the corneal endothelium, and the IOL pieces are cut in two pieces, or IOL fragments are made in a controlled fashion so that we don't touch the corneal endothelium.
Can I ask?
Hello, is the video visible?
Yes, it's visible.
I think there is a lag.
Moving
or is it
slowly.
playing in a very slow motion?
Yes, it's going very slow. Yes.
Sanjay, can I ask a question?
Yeah.
Yes.
Was it an unusually cold day, or was it that the blow of the AC?
AC temperature was literally on the 16th on that day.
I think sometime it could also be that the lens was stored in a very cold place and it did not get adequate time.
So we keep the lens outside the operation theater, so that it becomes very warm and malleable. But here the problem was it was loaded way before the IA procedure was done. So it got stiffened in the cartridge itself.
Yeah, maybe these are the cases wherein if you have do a screw type of injector, maybe I wanted Dr. Ramurthy to comment on this. Instead of pushing it, if you had a screw injector, this kind of breaking up may not have happened because of a more controlled entry.
I think Dr. Sanjay already mentioned the answer in the sense that irrespective of going into why this happened, whenever you feel irrespective of the type of injector you're using, if there excessive resistance, is better not to force the lens inside. It might be because the appropriate cartridge in the intraocular lens is not matching, or there is overriding of the plunger onto the optic of the lens when you have this problem. So whenever you face a situation where you have to excessively force the lens inside, means whatever be the modality of injection, it's best to withdraw, inject it outside. Very often you'll find that the lens is broken into pieces. Go for an alternate lens so that you don't end up in a situation like this. Of course, he has handled it quite well. Only comment I would have is that, like Abhijit showed, it's always a good idea to have a lens holding forceps through the side port so that it stabilizes the lens. And then you can
always have a second instrument from the left side of the side port to support the IOL. So many times these scissors, they are sterilized and repeatedly used, many times used. They may not work every time effectively as they are fresh. So it's always better to support the IOL fragments. They have a tendency to tumble and touch the endothelium or give jerk to the PC.
I feel that not only did it get hard, but I think it also got adherent to the sides of the cartridge because it didn't crack. Instead, it's the periphery that got sheared.
So, yes. It was inappropriate size of the cartridge also.
Yes.
Was it a very high dioptered lens?
No, it was routine 22.5.
And did you put in viscoelastic at the tip of the cartridge also in the interior part, apart from in the butterfly? Did you put it also in the?
No.
Probably there also, if you would have put in, it would have probably helped in lubricating.
Can we rewind the video and see where the actual margins are cut off? Is where the cartridge is actually holding onto those margins at that time when you're folding the lens. So this is probably also, as Dr. He has described, it's probably incompatibility of the cartridge to the lens. So good idea for all the newcomers and whoever start off with new lenses is to actually check the folding of the IOL after the cartridge has been loaded under the microscope before you inject the IOL, because that's where the entire problem happens.
While we are talking on the optics, these issues, sometimes it happens that the haptic of the IOL is stuck in the cartridge. Now, can you tell us
that is a
but here it is properly positioned. Can you see
not
this?
In this. No, this is all right. This is properly
folded.
Yeah.
But there was no visco in the anterior
part is what she's
anterior, see, you see the anterior part here.
Yes.
Anterior part is filled with the visco.
It's filled there. Okay.
One thing which I do once the IOL breaks inside.
Here itself, I could have stopped.
It feels broken actually, but.
No, the distal part is broken, crushed. The proximal part was okay while injecting. Here itself, I was feeling the resistance too much. I would have abandoned at this stage only.
This is the incompatibility of the cartridge to the IOL.
Correct.
Okay. So if the trailing haptic is stuck, Swapna, can you tell us how best you would handle it and what could be the cause for that?
Well, there are two things to it. You have a 3-piece IOL. Sometimes the way you fold it may get the haptic caught, but it's rather easier to handle because it's a single haptic there. And that can, just with gently maneuvering the injector, you can use, you need to use an additional dialer on one side. You can maneuver it out. But if you're talking about a single piece IOL, something like this, where the haptic has got caught between the plunger and the base of the injector, then it may get pulled and there's a high possibility that may get torn off. So with one attempt or so, if it's not coming back, I would rather try to get it out than an implant.
Or maybe even make a small nick on that overlying cartridge and increase the space for it to get injected into the bag. We shall now, thank you very much, Dr. Sanjay. We shall now go on to
I wanted to make.
Yes.
One of the things I do additionally is once this lens is broken when we have injected it, I go ahead and bring it into the anterior chamber and then do an IOL scaffold. I put another IOL first and then
That's the idea.
cut and remove this IOL.
Yes. Correct. It's a very good suggestion. Makes sense. Thank you very much, Dr. Sanjay. Can you stop your video?
Yeah.
We shall go on to our next speaker.